Afternoon, good evening, good morning, viewers. You're welcome back to another episode of Monitor Your Health, the program where we educate the community about topical issues around health. Today, we have a very important topic to discuss. My name remains Dr. Femi Ogunremi. I'll be your host, and I have with me a Professor Kayode Osagbemi. You're very much welcome, sir.
Thank you very much. Good morning, good afternoon, good evening, not good night yet.
All right. One part of the world is good night, I think, is approaching.
Yeah.
So, please, can you just introduce yourself to our audience today, sir?
Okay, thank you. My name is Kayode Osagbemi. I'm a medical practitioner. Basically, I'm a doctor. I'm based in Ilorin, Nigeria, where I work as a consultant public health physician to the University of Ilorin Teaching Hospital and a professor of public health and disaster emergencies to the University of Ilorin. So I've had quite a considerable experience in public health spanning over some 3 decades. I have special interest in disasters and public health emergencies, including epidemics. So in the present dispensation, I'm the apex of the COVID control, epidemic generally, and COVID control in my hospital. I'm also a member of the special task force of the Kwara State, Task Force on epidemic response, particularly to COVID-19. So I've been part of the team that we have been working for the past 3 months thereabouts, particularly on that condition. Thank you.
Thank you so much, sir. So now, COVID-19. This is just a name that every household worldwide now have to reckon with. It has come to ravage our world, and it's really ravaging our world. Whether I won't say positively, and I don't want to say negatively. Now we know that there have been a lot of things that, yes, there's been a lot of things that have been happening. And we know that one way or the other, in Nigeria in particular, in fact, worldwide, we seem to start relaxing with the lockdown. And looking at the trend, there seems to be increase in the number of cases now. Are we having the second wave, or is it still the first wave that's yet to finish, sir?
Well, I think it has become a propagated form of epidemic from one wave to the other with many sinusoids. That is, one down, one up, depending on the country you are. But generally, there's no doubting the fact that the trend is gradually and has increased. Some say we are at the peak, but depending on where you are talking about. But focusing on Nigeria, I want to recall that the disease was first diagnosed somewhere in China, from where it spread to Europe and the Americas, and then to Africa. In Nigeria, transmission started gradually and has increased. Some say we are at the peak, but depending on where you are talking about.
Sorry, sir. Okay, you can carry on now.
Okay, so transmission has been steadily increasing since the onset when it was first diagnosed about some 2-3 months ago. Now, but first thing to clarify is that the disease is basically from animal to animal. At a stage, it became from animal to man, to human beings. And now it came from human being to human beings. So initially, it was dependent on contact with somebody who has traveled to those parts of the world that have been affected. If the person has come into Nigeria and come in contact with that person, that's a form of transmission, from the importation, so to say. Then gradually it started affecting our health workers and then the hospital system. So people who came in contact with our health workers who are affected, or people who came to the hospital, one way or the other, got into the community. That's the basis of the so-called community transmission, which we are seeing. Now, when was a health worker hospital acquired and all that, it was relatively low. But now that it has gone to the community, then the peak, we are getting to it because the trend is increasing daily. And there's a gamut of information almost every day and everywhere in the world. And in my decades of practice, really, I've never seen any disease that has enjoyed much data and information like this. Take Nigeria, for instance. I know that our most official source or credible source is the CDC, Center for Disease Control. And we have seen that every day they are giving us updates. There's no single disease that they have done like that, as far as I know. So there's gamut of information. If you take today's newspapers, so many information, they've given a breakdown of the transmission. Somewhere you have put COVID-19 fatalities to rise in Lagos. The COVID-19 Africa death toll hits 9,000. As Nigeria records 4 fresh cases. All these are today's papers. Some states are threatening lockdown again. So many information and data are available. So the community transmission is really the stage we are in now.
Right. So, I mean, community transmission, it's quite scary. There's a lot of panic. There's a lot of fear. What do we mean by this community transmission?
That means it goes from one person to the other that are within the community, not necessarily from health worker to community member, or from health worker to health worker, or from animal to man. From, if you go to a market, for instance, I are not protected, and there's a person that is a carrier, not even necessarily having symptoms, and can transmit to you. So it's within the community, not necessarily within the hospital acquired or having information or contact with hospital system. So it can spread gradually, and the moment one person gets, there is capable of spreading it to so many people. So that is why the community transmission is being emphasized.
This community transmission, I think, looking at our culture in Nigeria, I think is a big thing, because there have been, cases where people who probably have, COVID-19 would die. And when we look at the way dead bodies is being handled, could that be a major risk? Could that be an issue?
Yeah, most of our cultural activities constitute maybe factors that can enhance transmission. But at the same time, we have to look at the importance of culture in our own system. Remember, our healthcare is not just absence of diseases, but also our psyche, our mentality are involved in our healthcare. We have a lot of respect for the dead. We have burial rights. We have so many things that we must perform. And that brings people together, and even in contact with the dead body who may be a suspected or even a confirmed case. Then we have weddings, burial ceremonies, religious activities, the mosque, the churches, and so on. These bring people together. So this have the tendency to enhance the transmission. But be it as it may, there are factors that we already have in place to reduce those transmissions. We'll go to that as the discussion goes on.
Thank you, sir. So obviously, because of this pattern that we have discussed, when COVID-19 started, a few months back, I know that there were a lot of measures that we tried to actually use, and I know that one of its mostly is to lock down. We lock down the cities, we lock down everywhere. No interstate travel, no intrastate travel, and obviously looking at statistics, one way or the other, things seems to just stay. I don't know how much we actually observe that though, because I think it's something that you might throw lights in. It asks for us, but we've tried these measures to lock down. Did it work?
Well, lockdown is the term used for restriction or cessation of movement of people, probably with the exception of certain services and so on. We started it about 8 to 10 weeks ago, and various parts of the country observed it at different levels. Some states did not even lock down at all. Some states did partial lockdown, and but the point is that apparently the rate of transmission then was probably slow. But the major reason why probably it has not worked the way it should, well, we have not done absolute or complete lockdown, which is not practicable in our own environment based on the socio-cultural things mentioned earlier on. But to say whether it has worked or has not worked, well, we are seeing that when the lockdown was relaxed, then the trend increased. So based on that, you may say lockdown is there, but we had the impact and the effects of the lockdown itself, which are immeasurable. Take, for instance, our health system completely was shut down or paralyzed, meaning that COVID-19 eventually took over almost everything. People remember that the other diseases in the communities are still there. COVID-19 has not replaced any of the diseases, it has only come as an addition. So hypertension, diabetes, sickle cell disease, cancer, HIV, other communicable diseases, malaria, pneumonia, all of them are still there. So, but the attention was shifted grossly, to COVID-19 at the expense of that, including infrastructure. Many of the health facilities were not opened, and all of that. That's one major impact or effect, which is negative, so to say. Now, if you look at our socioeconomic setting, the ports were closed, markets were closed, churches, social activities were banned, and Africans, Nigerians, we are social people. We like entertainment. Entertainment industry paralyzed, income. Then the mental status, even of people were locked down, they couldn't go out, they were stripped in, services. Then, most importantly, poverty was coming because there are people who dependent on their daily living to survive. Meaning that you are an artisan, you are a mechanic, you are a hairdresser, you are a tailor, all the artisans, they could not move. So the little money they had were exhausted. Then came in the issue of palliative. Palliative, became more or less politicized. And in other parts of the world, where they are probably better prepared, they may have better palliative. But here, if you ask people to give food all over, how many people are you going to give food to? So hunger became a problem. The main benefit may be then, even about the socioeconomic, the government locked down the custom system, but by that, so the main benefit that really accrue to the common man on the street probably may be the reduction in the fuel price per pump, like from I think 145 to 143. The reduction or the postponement of tariff on electricity, because we are supposed to have been paying more for electricity. It have been started maybe a few months ago, but they say, okay, postponing. Those are the few benefits, apart from the fact that transmission may have reduced. Look at but the benefit mainly went to the conglomerates, because you reduce custom tariff, you cut down the budget by about 1.5 trillion, which means that our spending capacity is reduced. Then the custom tariff, other duties, and tax relief were given to companies. So really, the real benefit of lockdown went to the conglomerate instead of the common man on the street. So to talk the impact and the effectiveness of the lockdown, and our people, you see, when you are bringing a system that has been done somewhere else, you have to customize it to our own system. Don't tell people to sit down because they must move. And therefore, there came some level of resistance. People were agitating to go out. And then gradually they began to ease the lockdown. And then we have now seen the resultant effect of increase in the transmission.
Wow. It's quite kind of a bit complicated in Nigeria, because when we look at other parts of the world, especially when in the area of this palliative and how that supports the system, it looks like we struggled in Nigeria a bit around this area, just because some of the things that you have said. So, what is the result? I mean, the effect of this now, looking at where we are. What can we see? I mean, where are we going?
The important thing is the fact that it's not advisable that we continue with such a lockdown, because we have seen that is unlikely to reduce transmission in the sense that the partial lockdown, in a week, you lock people down for like 3-4 days, then you open them up to transmission, lock them down again. When you look at the principle of epidemiology, it's of no practical value because the 2-3 days in a week is enough to perpetuate or increase the spread of the disease. So the lockdown, to the scientific mind, is of no practical value. Of course, initially, the fear was that, okay, if everybody gets infected, we are going to almost, the whole of entire Africa might be wiped out. But luckily, the thing did not turn out to be like that. You will see that if you look at the transmission rate and infection rate within the African setting, it's relatively low compared to other continents. Why? Probably because, one, the environment itself might be hostile in terms of the sunshine, the brightness, rainfall, so many things might be hostile. Then if you look at the age distribution, in the most affected mortalities of the world, they tend to have the older age group. In Africa and Nigeria in particular, 60% of our population are under 60 years. So these tend to have better level of immunity. Then we also look at our access to drug and medications. In Africa and Nigeria, you can walk into health outlet, pharmacy, chemist, and procure any medication. All these are things that can help to boost the herd immunity, so to say. Then our diet, okay, we plug things, we take natural food and all that, instead of the processed and over-processed, so to say, genetic modified consumables. So then, if you look at our traditional remedies, okay, many of our food contain herbs. There's some vegetables they believe if you consume them, they may help. Now, then if you look at our genetics, people are saying that, okay, probably because of our genetic makeup, so many things. Then you will see that some trials have been made with chloroquine and all that. You can imagine how the quantity of chloroquine we have consumed in Africa and Nigeria before the last 10 years. So these are things that can be built up to make us, have the so-called low level of mortality. I mean, if you look at hardly has any African country gone more than 3 to 4% mortality. So in short, the lockdown practically has not really contributed, but were it to be in a situation where the mass transmission and mass casualties like other parts of the world, then lockdown probably might have reduced it.
Thank you so much, sir. So now, if I look at individuals, especially the viewers from home, I'm sure they'll be thinking, yes, this pattern we've seen, the way it is in Nigeria, that we said that fewer people have been affected. But the question that people might be asking is, compared to other countries, are we actually testing enough? Are we testing people for us to say, categorically that, yes, the level is actually lower? Or is it that things are being masked?
It's a mixture of so many factors. But actually, to say whether infection is increasing or not, it's a difficult thing. We're only saying that the more you test, the more you see. Now, there are some states in Nigeria, for instance, they've not been testing and they are not seeing. That does not mean the condition is not in those states. So, meaning that even the anomalous increase we are seeing now is because we are doing more tests. If you take an individual, for instance, that tests positive, we have to do contact tracing, go to the homes, take the wife or the husband, the children, the relative, the driver, and tell everybody. So the chances are that we are going to see more based on our testing effort. So that we are scoring low probably it's not the important thing there. The important thing is that if you look at the number of people affected compared to the number of people that die, then that is why I would say that we are relatively protected, meaning that the case fatality rate is relatively low in Africa, including Nigeria. So that is the basis to say that masking, imagine if you are saying case fatality rate of that's the number of deaths compared to the number affected, if you are talking about less than 2.5% or thereabout. For other epidemics, when they come, yellow fever, Lassa fever, measles, cholera, case fatality rate, jumps from 10% upward. So this one is relatively low. That does not mean that the death of one person is not of importance to the country, to the family, and so on. But if you now look at the health of the population compared to other epidemics, then that is why we feel that we still have some level of protection relative to other parts of the world. So testing is good. We are making effort. We are getting data, delay, and all that. But the expansion of tests and so on, they give us more cases, but we have to begin to, because the disease continues to evolve and we are studying it as it goes.
Thank you so much, sir. Now, the other issue that I think it might be good to actually explore is when we look at the community. Yesterday I was going to work, and this is in Lagos. And as you drive, you see people, the way we interact. Obviously, with our culture, which you touched on earlier on, we're very close. And then if you look at buses, you look at the way people still park themselves. In fact, I had to take Uber yesterday, and the Uber driver that took me, we almost fought because it's like I'm really paranoid about this whole thing. When people wear there's this pattern of face mask that everybody use now. It sort of cover their mouth, and then you see their nose, they're just blowing everything out like that. So you're another, look, I'm not comfortable with this kind of a thing. I have to carry, the surgical mask in my bag, and I give people as I go, please just take this one if you're gonna come close to me. It's quite interesting. So how does that affect the community, in terms of the transmission?
Yeah, as we have said earlier on, we have some protective natural herd immunity. Maybe because of chloroquine, maybe some other immunization we've had before, cross immunity. Remember, the COVID-19 is not the only coronavirus in the world. And coronavirus was in Nigeria before. It's only this strain that has just come. So probably some cross immunity have come. So that's probably what is helping. Now, the issue of compliance with health regulations. Issue of face mask, because the basic health regulations are constant hand washing, regular use of the hand sanitizer, the face mask, okay, the face shield, have mine, the eye goggle. All these are recommended, especially when you are coming in contact with members of the public. But compliance with it is very difficult to maintain, just as even the lockdown itself. By the time itself, people should not move. You saw people were moving, even at odd times. We found their way with the security agencies and so on. So it was practically of no value. The same thing. We want to enforce use of, behavioral change communication. It's one of the most difficult things to achieve, especially with due sense of humility in our own environment. Before you just tell somebody, don't go and bury your father, don't stay close to don't kiss your children, don't hug, don't do that, don't stay in the bus, don't do that. See, it becomes a lot of restriction. But the bottom line is we don't give up. So we continue to hammer, see importance. Remember, when the HIV came, because right now some people still don't believe that COVID-19 is real. When the HIV came, initially it was very much resisted. People said, oh, AIDS means Africa intention to discourage sex. And they were so passionate in rejecting it. But with time and with increased persuasion and with people getting more affected, the use of condom increased, and probably one of the factors that reduced community transmission. So all these measures of face mask, this and all that, we keep practicing them because those are the things we know for now. And after all, those are the basic hand washing, personal domestic hygiene are the basics of really sanitation before. These are just additions. So people put the face mask on their neck, put everywhere. People don't even wear it at all. We continue to tell them. And then some of them, when they see other people affected, that may influence their attitudinal change.
Thank you. I mean, the issue of compliance is quite big. And from my own personal perspective, I think it's one thing that we really need to look into, because obviously, if we can't, we're lucky, just like you said, sir, that the case mortality rate here, fatality rate here is quite low compared to other parts of like in Europe or America or things like that. And I think compliance is quite good. I'm saying this because of our viewers who are watching. A lot of people do not understand why they even need to even wear the face mask. The guy who I was talking to yesterday was like, this thing is just hoax. There's no corona. There's this thing. Okay, if you want to use it, I'll use it for your sake. Not for his own sake. He believes that it's well. I'll just shake my head. So it seems to me like the community enlightenment is really still below the threshold that we should be expecting. Or what do you think?
Yes, the community enlightenment may be below, but the mindset is also important. Many people don't believe something is a reality until it happens to them or to somebody they know or a close relative like that. So we don't want to wait until that point. But it's like putting on the whole armor. We keep talking about the community sensitization, mobilization, awareness, and so on. So to say that people have not had is not really the issue. It's to comply. That's the major factor. And just as I said, with HIV, the use of condom, compliance was very difficult, but eventually we were able to achieve measurable success. So this one, I'm optimistic. Of course, we expect a lifespan of the outbreak itself. Based on previous experiences with other virus outbreaks before, that okay, with time, maybe the trend will go down. So by the time the trend will go down, then we begin to adjust to the system. But you see, for practical sake, how convenient would it be for somebody for the next, let's say until a measurable number of months, to put on face mask, wash hands, and all that? What's lockdown? For how long will you keep people in their homes without going to work? You can see the schools, they cannot open. My children have been home for more than 3 months. You say, okay, you want to lock down again for another 2-3 months, then you are paralyzing the whole system. So, but as I said, community engagement and awareness is a process that, should be able to reduce the pattern of transmission. I can see a downward trend, in the curve itself.
Thank you so much, sir. So, you touched on quite a number of very important topics, and somebody just asked a question. Let me just take this question, quite interesting question, actually. He said the government at all tiers has shown to the public that they are more interested in the COVID money from WHO instead of providing health services, instead of proving how serious this is to the public. Is there really COVID-19 in Nigeria? Well, very interesting question.
Yes, that is the general impression of many Nigerians, that it is a way of taking money from WHO, from donor, and all that. To some extent, most of the activities we have been carrying out have depended on donors. And really, if you ask government to fund everything, I don't know where we'll be as at now. So it's a donor-dependent situation as we are. So to say it is really or not really in Nigeria, I can categorically tell you, based on available data, testing, and so on, it is real. I have seen cases, I have treated cases, I have managed cases, I have seen death. So that is real or not real, it is. Now, whether they're interested in the money or not interested in the money, issue of corruption, why people are corrupt, they take the money, why they money, beyond the scope of discussion per se.
Hello, sir. Can you hear me?
Yes, yeah.
Yeah.
I can hear you clearly.
Okay, thank you so much. Now, yeah, talking about, an aspect that you talked on earlier on, I'm just taking us a little bit back again now. You talked about, chronic diseases. We talk about things like hypertension, diabetes, we have cancer, we have all these things that are still there. They've not gone, they're there. And then we have this COVID that is actually, ravaging our world now. When the whole thing started, there were a lot of debates or discussion around, this is an opportunity for us as a country to get ourselves together and be able to look at, our healthcare system and see whether we can actually take this as the NIDOS to actually improve the health sector. And I sort of linked that to this question that this person asked. At the point in time, there were a lot of discussion in the public domain that there is no money again. Even the donors' money is all gone. At the point in time, we heard that one place was burnt in Abuja, where there was supposed to be palliative care, palliative money, and things like that. Of course, a lot of things. Nigeria is a place that I think is very difficult for you to get the truth about a lot of information. To get the truth about information.
But when it concerns money.
It's kind of worrying when you hear such things. So then people can start asking questions like this. Well, now that I'm here right in front of you, I think I should ask that question. What do you think about all this?
All this is that the thing has given us an opportunity to refocus and look at our system and see how to develop our health system to be able to cope with the realities of our country. Meaning that the quick travel for healthcare system, other parts of the world, get services and so on, locked down so many people. And now it's an opportunity for us to say, okay, let us reposition. Let us see, let us think. When we come to our way forward, we expatiate more on this. But the opportunity must not be allowed to slip away. Otherwise, we'll be back to square one, which I think, though it has paralyzed other health services and those diseases, as you said, they are still there. But to go back to that system in addition with COVID would be a mistake on our part.
So what do you advise about those chronic illnesses? How do we get on? Because I look at yes, COVID is here. And COVID is causing havoc, no doubt about it. But if we continue to focus on COVID and leave all these chronic diseases, we've been trying to push down, for some of them, either the mortality rate or morbidity rates. Everybody's been trying to push that down. But this seems to be like a setback. It's pushing us back a little bit. And we're not doing anything about it. I'll start an example, sir. I got involved in a project recently where we do screen ladies for breast cancer, and we picked quite a lot of people at a very early stage, and cervix as well, who were meant to follow up, and then we got shut down. Everything got closed down, and then we couldn't move. And this patient are there. We picked them early, but we've left them, and then to their fate, to be honest, in a way, because there's no how we couldn't do anything, and this would be like what we're trying to help. It's going to be something that will stare us in the face. So what do you advise? How do we manage this system?
Yeah, that in one of my earlier discussions, another forum, I pointed out clearly that the other diseases, both chronic, communicable and non-communicable, they are still there in the communities. And COVID has not replaced any. In fact, it has come as an addition, so it's more burden for us. Now that we did the shutdown, paralyze all those systems, as I mentioned earlier on, then those conditions, mortality and morbidity due to them, continue to increase. So we should reset our mind back and pick up from where we dropped, from your screening to treatment to counseling, clinic. You can imagine in the last 3 months or so, in the teaching hospitals in Nigeria, most of them did not run any non-communicable clinic at all. Even the people that were hypertensive, diabetic, to go to clinic and pick their medicine and measure their blood pressure, have been paralyzed. So we need there's an urgent need for us to now refocus. While we still tackle COVID, we should not forget all other health conditions, particularly those chronic conditions, as well as even malaria, other fevers. Okay.
Okay, thank you, sir. We're having quite a lot of questions coming out from the public at this point. I think I have one that is saying here, those numbers declared by NCDC, are they real? Are they overhyped or undermined? That's one question.
Okay, let's take that one first. The reality of the figures from NCDC. Before now, most allusions are that when it comes to Nigeria, so many African countries, they will say no data, no data. So at least we have data. And we have to follow it down point. At a point, we need to take information. Now, the only official information that's credible is the one that is from government. We have the World Health Organization, which sets standards for us, and the way we have to go about things, we follow them. We have our own local counterpart, so to say, of the NCDC. That's the only one we have. So we have to take it the way they have given us. Whether it is correct, whether it is underplayed or hyperplayed, so to say, it's difficult for me to determine or for me to answer to say that. But that is the only one we have, and we have to work with it. Thank you.
Okay. I think these other two questions, we touched on them, but I'm just going to read them. So that somebody said, where is the place of diseases that pose threats to people being solved? Because all attention is now focused on COVID. So they're just asking for the place of, I think, the chronic diseases that you mentioned earlier on.
The answer is that we need to refocus. We should not allow COVID to overtake our health system. And one of the ways not to do that is at least to unlock and let our clinics run and let our screening programs run. Let people come to test their blood pressure, their blood glucose, their level of health system and our health status. Then we begin to reposition ourselves in addition to COVID. So we should not allow COVID to overtake our system at all. That's the only way we can move on.
Now, what is the role of technology in this? Because I sort of look at it like, if the worry where people are not coming out is because people are thinking, okay, when I'm in my house, I'm safe. If I go to the hospital, that's where people that will have COVID will go to. And then people don't want to be in touch with the virus itself. So could technology be a kind of instrument that will enhance the optic of this? How much can we do from technology? How much can we impact? Because that's one thing I sometimes look at, whether it might be.
Yeah, technology, particularly telemedicine, telehealth, health information management, and so on, is to our advantage. If you look at a situation, we've done some pilot studies where some doctors will sit in a clinic, members of the community can call in, make complaints, non-prescriptive medications are made, and to a large extent, we were able to get some success. So we can leverage on such researches that we have done all over, meaning that you can measure your blood pressure at home. You can call your doctor and say, okay, I'm having this level today, or even the blood glucose. And then doctor will say, what level of medication are you taking presently? Either you increase or you reduce. And then you can monitor like that instead of everybody coming to the clinic all day. Then look at our children, go back to school. Many of them have begun their assignment, their training, some of their lectures, even online. But to some extent, while this is a big advantage and reduces the man disease or parasite or virus contact, is good. It's a way for us to leverage on our development technologically. But we need to be very careful in the sense that whatever you have not prepared for is likely not to be successful. Meaning that our system was not initially prepared to translate to informatics or health information like that. So while we grow in it and develop it, we should grow it along with part of the traditional system as well as advance with the rest of the world in terms of health information and telemedicine and telehealth.
Thank you so much. Right. So the next question said more people die from other diseases. I think it's still other diseases. Why the Nigerian health sector's not? Why is the Nigerian health sector not talking about them and focusing on COVID, e.g., meningitis, diabetes, cancer, etc.? I know you mentioned something around that earlier on.
Yeah,
I don't know whether
talking around the same concept that COVID-19 should not be seen to replace our health system, that other health condition diseases are there. So at our level as experts, so to say, advisors, advocacy, we are still working on the government and everybody, including the people themselves, so that we put on the whole armor and don't neglect all those other diseases at the peril or at the expense of other diseases and focus on COVID. COVID is just addition. Other things are still there. People are still dying from all other conditions that we had before. So the message here to both the government, the international agencies, and even to our communities and community members is the fact that let us not forget that other health conditions are still there in the community, and we should go back and reorder our priorities.
Thank you so much. So now we have about 4 or 5 minutes to round up this program. Now I want to ask, I mean, from your own professional knowledge and things, what will you be advising our government?
Okay, the way forward is that the protective factors we mentioned earlier on, we should research into them and develop them. You see, there's one concept we call One Health. The relationship between man, animal, and plant. So this is an area of we can hammer on and develop more, because human beings will eat plants, animals will eat plants, and this is a disease of animal that has come to man. So we need to focus on the role of, in fact, even the transmission we are saying, even if we are focusing on just the human beings alone, what of other animals? We are not sure now whether even our pets and all at home are already having the COVID, and then the spread and so on. So we must focus the tripartite, then look at our traditional remedies. How do we develop them? After house pharmacology, called African pharmacology, in quotes, which we can develop. Look at our herbs. We have reputable pharmacologists in Nigeria. We have pharmacists. We have virologists. We have epidemiologists. We have laboratory experts. All, because many of our people have gone elsewhere in the world and they have excelled. Look at you, for instance. You are a social mobilization and community communication expert. And behavioral change communication is an area. So come. Then you also look at the pattern of reinfection. Whether somebody who had it before, has it come back again? How do we now live with the virus? Those are some of the way forward. The behavioral change communication. For now, the face mask, hand sanitizer, the goggle, the shield, all we should put on the whole armor. But let us continue to look into our own and stop depending on the so-called international organization and international world, because the donor dependency syndrome will eventually set in even with COVID. You can predict within the shortest or the short possible time, the donor fatigue will start. So how do we build on what we have and then move forward from there?
Thank you so much, sir. Now for individuals, a lot of people are quite worry sick as we talk. If you hear COVID, people just panic because people believe that you get COVID is like a death sentence. Of course, in Africa, we've been very lucky. What word of advice do you want to give, to our viewers who are thinking, what do I do as an individual?
As an individual, the first thing is to get the right information. The right information is the fact that COVID-19 is not a death sentence. Number two, if you protect yourself and protect your family members and do household hygiene, domestic and household and personal hygiene, they are protected. Take, for instance, if 100 people come in contact with the virus, 80% will not even show any symptom or get infected. The remaining 20%, out of the remaining 20%, only 5% will show symptoms, out of which a few will die. I'm not saying it's important for or to trivialize death, but if you look at the way people will die from malaria, people will die from meningitis, people will die from measles, people will die from other diseases, stigma, we should remove it entirely. The fact that somebody has come from an isolation center, has been treated, is fine, should go back to his work, go to his family. People should not see them as being special. I remember those days, if somebody was said to be HIV positive, wow, everybody tended to run away. But now, gradually, they have been accepted. So we should not stigmatize, and we should not see COVID as an aberration to our system. We should still live our normal life while we stay protected.
Thank you so much. So viewers at home, thank you. You've heard it now. COVID-19 is not a death sentence. Of course, you have to take care of yourself. You need to protect yourself. There are things that you need to do that I believe in this talk, you will have picked one or quite a few things. Oh, wow. One question just came in. We accommodate this question. Say asymptomatic people, are they potential risk carriers? Because I know some people have it but do not know.
Yes, asymptomatic carriers can transmit the disease, meaning that if somebody is infected, he doesn't cough, he doesn't sneeze, he doesn't have sore throat, no diarrhea, no difficulty in breathing, nothing. Because the virus may be in his respiratory system and his throat, and if he coughs and spits or anything like that, then the virus can get to another person. So that is the basis of protecting yourself first. And then if the person even potentially has it and does not know, if he protects, then he cannot transmit, it's not likely to transmit to another person. That's why the social distancing, personal protective equipment, hand washing, and so on. These are the way to reduce person-to-person transmission, because just like many other viral diseases, they do not show on the face. The disease does not show on the face until the person has symptoms.
Yeah, the WHO said something not long ago. I'm not sure. I think I saw that briefly when they were talking about that asymptomatic carriers. Maybe they don't transmit. I don't know. They don't transmit. Is that really real? Or I mean, it's quite difficult.
My take on that is that it is still an evolving disease. You cannot practically rule out and say these are not. Whatever they have found in a few number of studies of few people may not generally apply to us, particularly in Africa. So to just say that asymptomatic carrier cannot transmit, the bottom line is the virus getting from one person to the other. And the person that is carrying it, transmitting to another person, even the person picking it, maybe they want to show symptoms. So we should not let our guard off at all based on the fact that, well, WHO may say, but we have to also adapt to our own system.
Thank you so much. It's been a pleasure to have you on the program. I really appreciate you, sir. Professor Osagbemi was my lecturer in medical school, so you're our daddy. So thank you so much. Really appreciate you for your time and to come and impact here. Now, viewers, thank you so much for joining us today. I hope you've learned or you pick one or two things from today's episode, and you'll be able to at least look forward, looking at what we've talked about, see how you're going to protect yourself, protect your family. Don't forget, infection, if you have one virus that hits your body, okay, leave it for 10 hours. You have about 1 billion of it. So one way or the other, what you need to do is wall yourself off. Your protective gear, just like Prof has just said, Do not let off your whole armor of protection. It's really important wherever you go. For this week, we want to say bless you, and then have a nice period during the week. Thank you.